Hello again, and thank you for joining the second Manuthera webinar. My name is Vili Rahkonen. I'm here with Kevin Collet. And first of all, I want to thank you from the feedback we got from the first session. It was a real success. We had over 600 people from over 50 countries. So really an international audience. So we really want to thank you for that. This time there are over 300 of you who participated and from 46 countries. So we are really happy to have this international audience from you. Thank you. Just to mention a few countries that are participating, there are people from Azerbaijan, Thailand, Germany, Canada, Trinidad and Tobago, and of course our dear friends from Sweden. Welcome and thank you for joining. Today's topic is low back pain. World Health Organization has studied that in the industrialized countries, 60 to 70% of people suffer from low back pain during their lifetime. So this is a really major issue. In the US alone, annually 149 million working days are lost due to this problem. So this is a major problem in the healthcare industry. What causes the low back pain, and is there some way we can examine it or treat it? Hopefully we get some answers from Kevin today. And before we start, we want to mention that there's a chat in the next to the screen. Please ask questions, comment the content, and if you have more questions, you can also write us email. You will find the email address there. And below there's also a link to our self-learning platform where you can find a lot of more information and content on how to utilize Manuthera and what can we do with it. Okay, now I think it's time to give the microphone to Kevin and let's get started. Thanks again for joining and please be active in the chat. Thank you.
Thanks, Vidi. Thanks, everybody, for joining us today. I'm very glad to be here for our second webinar. Now, our topic today will be lumbar spine. Last time we had a webinar, we spoke about thoracic spine, and of course, thoracic spine is still something we should keep in mind if we have low back pain. But now, for our topic of today, we will really concentrate on this area. Now, we know that low back pain is a pretty common problem. In my clinic, I can say that on a daily basis, I have patients with low back pain for different causes. Today, what we're going to speak about is mostly this area and assessment and treatment of this area. Now, of course, in my clinic, if I have a patient with low back pain, I would first have an interview and I would think about differential diagnosis and maybe do some specific tests for that to make sure that the pain is coming from this area and that it's something that I can also treat manually. So I would have done my active assessment of range of motion, and then I would have a look at passive range of motion. So that's what we're going to have a look first. Included in my active range of motion testing, I would also have a look at the hip, the thoracic spine, the SI joint. These are very, of course, important areas because they might have an influence on the function of the lumbar spine. Now, to keep in this area, the things we're going to have a look first is assessment of the passive range of motion of the lumbar spine into flexion, extension, sideband, rotation. And then we are going to use the same movement to have some mobilization. So the aim of the passive range of motion assessment will be to check, do we have some movement restriction, maybe in some area, or maybe even too much movement in some area. And our focus will also, of course, be on the areas that need more movement, because it's easier for us to add movement to this area. And then if we have too much movement in some area, of course, we have tools for that too. But we are now concentrating on these area which are restricted and maybe have some mobilization there. So this is the first part we will think about. Assessment of passive range of motion, and then we'll go to mobilization. Then I'll show some techniques I use for soft tissue and fascia using movements. Also, how we can combine three-dimensional movement with treatment of these areas. And then after that, we'll see some more specific techniques, some special techniques using spinal decompression and some foramen opening in some special cases. Then we'll speak about traction, and we'll end up with the drop. So that's about the plan for today. So to show you first the assessment of the lumbar spine, passive assessment, I would have first my contact on the spine, and if this would be the spinous process, I would put my finger in between here. So I might have several fingers in contact, but my focus will be on one finger. So e.g., for example, this middle finger here, or here, or here. So I will be between two spinous process, and I will try to assess the movement and the range of motion I have here, but also the quality. Is it moving? Is it soft, or is it very reduced and tight? And using the movement at the same time. Before I show you this, I would like to show you that the movement we're going to use is from this lever here. So we're going to use the movement of the table into flexion, and then we'll go to extension, sideband, and rotation after that. Now, what I want to show you first is that it's pretty important that we make sure the patient positioning is optimal for this kind of movement. So if we think about the axis of the movement being in this area, we want the lumbar spine to be in this area. So I might ask my patient to come just a little lower, if you can come just a little lower here, so that at least the anterior spine here is on the table. So it's pretty important that we make sure the patient is in the right position first. All right, and then we can go for the assessment. So I will put my finger, as I said, between two spinosus process, and I will go into flexion and then come back to neutral. Flexion and come back to neutral. Then I'll go to the next one. And what I'm trying to feel is, do I have an opening movement between two spinosus process here? Now, in this case, I can feel that L5, S1 is moving pretty well. L4, L5 also. L3, L4 is pretty nice. And here in the upper lumbar, I have a bit of a restriction here, which actually I think it's pretty common, at least in my clinic. I've noticed that. Now, it's important here, every time I come back to neutral position. And from here, basically, once I've done that, I can go to extension. So again, my finger will be in exactly the same place, and I will go into extension from the neutral position here. So what I'm trying to feel is, do I have movement in each of these segments here? Now, once I've done that, I come back to neutral position here, and I will have a look at now sideband range of motion here. Now, I won't put my fingers in between here, but I will put my thumb on the lateral aspect of the spinosus process. So if that would be the spinosus process, I would be here. It's also very nice to have a large contact here with the hand and the thumb in a line, forming a line like this, and with a wide contact area on my patient. My focus is still here, but I'm not like pushing here because this is not so comfortable. So let's make it comfortable for the patient and have a large contact, broad contact, but still a very good focus here. So we'll open here and have a contact, nice contact on the lateral aspect of the spinosus. I will push gently with my thumb, and then at the same time, I bring the table toward me here, and again, come back to neutral. Again, L5, very good movement. L4, pretty nice movement too. And then when I come now to the higher part of the lumbar spine, I can feel a bit of restriction here. Now I would do this, of course, from the other side, but now I will go to rotation just to show you. For rotation, my hold with the thumb will be the same here on the lateral aspect of the spinosus process here. I will need the table to be a bit lower, and I will open on both sides here. Now the movement that I'm gonna have is this here. Now, as we know, the orientation of the facet joint in the lumbar spine is more in the sagittal plane. So basically, I don't have that much rotation in the lumbar spine. Depending on the literature, we have from a few degrees, maybe 1 or 2 degrees to one side, to, according to some, up to 5. Now, that's pretty much. We usually know it's, well, maybe about 2 degrees each side. So it's not a lot. We won't need a lot of movement, but still we would need some movement. So I will check for this range of motion on each level here. Now, I like to have the table pretty low for this technique because it allows me to have a good contact with my thigh here and the hand here. So basically what I'm just doing in pushing with one hand or then pushing with my thigh. So I'm pushing low or pushing low on that side, and then I get movement to both sides like that. So from here, I would come to my side, come back to neutral, and once I've done an examination on the right side, I would go on the other side. Now there are some different ways to do this. Maybe you could have the hand on that side and push and pull, or maybe you can have a hold here. It's really up to you how you like it. Personally, I like to use my body weight because it makes it very, very light and pretty comfortable for the patient as the movement is controlled and slow. Here, there, again, same findings. I can feel that restriction is pretty high in the lumbar spine. Now, it's not very surprising because, as you know, when you have a restriction in one direction of movement, usually you have restrictions in other directions of movement. So basically, it's not very surprising to have a good movement in this area. But in some cases, you might have only sideband, or the clearest restriction of movement might be in one direction. So it could be flexion, or it could be extension, sideband, or rotation. And you would, of course, treat according to that. So in this case, once I've done flexion and extension, sideband and rotation, now I would focus on this area for treatment. Of course, I would use my clinical reasoning and thinking about where is the pain. Let's say we have pain in L5S1 area, which is pretty common. I would, of course, be interested in the range of movement we have in this area. But I think it's very important to keep in mind that I won't focus too much on this area. I would have a look at the other areas to make sure that this is not actually, this might be the cause of pain, but this might not be the reason why this area is under strain. And maybe we have some kind of red light here, but the red light is just telling us that some other areas is not working properly. So my focus won't be necessarily so much on the area which is painful. I would have a look larger look on this area. Now, this was for passive examination. Again, I would have done my active examination first, maybe some different diagnostic tests, and I would have a look at SI joints and other areas. But now this is pretty important to have a look also at passive range of motion because it's a lot more precise than just active. Now, once I've done this, I would have a look at the area I want to work on with the direction of movement that I feel that it's the most restricted in the area which is the most restricted. Now, I will show you how I could use, again, the same movement using flexion and back to neutral. Let's say now in this case, we had restriction more in the upper lumbar spine. So I would go for a hold like this using my body weight, not too much, but still my arm is straight and my hand is kind of making a little curve like this so that I don't push on the spinosus process. It's not very comfortable. It makes it a little bit more specific, but it might be a bit sensitive. So I'm trying more to have focus on the transverse process and have a fixation with my hand here. So I will hold here and then bring into flexion until I can feel some kind of pull in my hand. I will feel that now it's kind of pulling in my hand. So I could use actually a pretty big movement, but if I make it very specific to this area, I don't need that much. And actually it's pretty safe and more comfortable and a lot more specific this way, to have a good hold and the range of movement which is needed. What also makes it more comfortable is to release when I come back here. So I hold, bring down until I feel some pulling in my hand, which is the applicator, but also at the same time feeling for this movement. Now I release it when I come back. So I hold, I bring, and then I release. And this movement should be pretty comfortable for the patient. So that would be more mobilization into flexion. Now, if I want to make it a bit more efficient or to add some power to this technique, I can use a bit of tilt of the table here. So the weight of my patient will bring the upper body down and have more intense fixation here. And now I can even bring further into flexion here. Now, usually a little of tilt is enough. This will be already pretty much powerful here. There. Right. So that was for flexion. Now, if I notice that I have some restriction into extension in the lumbar spine, I can use also the same movement. So I'll bring into extension and I'll make a gentle push from the vertebra I want to mobilize into extension. So in that case, not really anything specific here, but let's say, for example, L3 would be restricted into extension. I will have a hold on L3, and now I can push on the spinosus process. I don't want to make it too hard, and I don't want to have a hard contact. Maybe the hypothenar would be a bit too hard, so I would maybe rather use that area of my hand because it's a bit more comfortable for my patient. Here, so table a little lower so I can push down, and then I will bring into extension, trying to make it more specific with my contact here. Now, in some case, you might even hear some kind of spontaneous cavitation of the joint. It's fine. It does happen sometime. There. Now, during my treatment, it was important I come back to neutral. It's also pretty comfortable now to come back to neutral. I can even come back a bit further, like go into a bit of flexion. This will make the technique a bit more comfortable. So come back a little into flexion if you feel that maybe your patient is tensing or that you don't get so much movement you would like into extension. So this really is something that should be comfortable for the patient. It might feel a little of maybe pressure, but nothing like very painful. It's something I could do, of course, with the patient side lying. It would be a bit heavier for me because I would have to push with the legs and push with my hand here. So this definitely makes it a lot lighter for me. Now, this was more for mobilization into extension, mobilization into sideband. Again, I would go into sideband here, so I would open here. Again, what feels a bit more comfortable based on my experience, or mostly of the experience from my patient, is to use a little of flexion here. So again, I can use a bit of tilt here. So basically, when you use a bit of flexion, you kind of open the facet joints, so you make it a bit easier to get some movements there. Now, for sideband here, I can use the same hold I was just using here and pushing from the lateral aspect of the spinosus process. Now, my thumb is not really like pushing, creating movement. I'm more creating a fixation point, and I'm turning around this fixation point with the movement of the table. So again, it does look the same, but it doesn't really feel the same for the patient. I'm not really like pushing here. I'm just holding, and the movement happens at that level here around, creating a circle around this point. There and there. Now, if I want to make it a bit more efficient, I can have a hold with this part of my hand, which is, again, pretty soft here. And I can try to get a broad contact on the lateral aspect of the spinosus. It will be stronger than the thumb, but not as maybe easy to make it specific. So this needs a bit of maybe change in my position so that I get lower a bit, maybe table a bit higher, so that I can have the right contact in the right direction here on the spinosus here. So again, I'm not pushing on the spinosus, I'm holding, and I create the movement here. In this case, we have sideband to the right. Here. Of course, I could use that on the other side to have sideband to the left, but this is probably easier to see from that side. So, sideband, mobilization of the lumbar spine, and up to the thoracolumbar junction. Again, very important area also, so nice to consider also in this area. What I've noticed is that usually if I have some restriction, it would be really in the lower part of the lumbar spine, into sideband, or then the thoracolumbar junction. These are pretty common. Again, it can be right in the middle, L3, L4, for example, or L2, L3. It could be here. This I find, and I would say mostly the L5S1, I find it very, very important that we have mobility in the sideband direction in both sides, because this has, according to my experience, a large influence on the upper part of the lumbar spine and even on the thoracic spine. So sideband, pretty important, and yeah, something I like to check and treat. Now, for mobilization into rotation, again, now I will get the table lower. I make sure my patient is well positioned with the anterior spine here on the table here. I would take a bit of flexion, maybe a bit of tilt of the table. Let's take even a bit more, a bit of flexion here. So really, I feel that rotation mobilization is very nice and usually very efficient. But to make it comfortable, it's very nice to have a bit of flexion. Otherwise, if we are in a neutral position, we already have a bit of extension, a lordosis in the lumbar spine. So we might have a bit of pressure on the facet joint. So this really makes a lot more comfortable. Again, good hold here with my thigh. I'm standing above here, my patient, and just pushing with my hand and with my leg. Now, we had some examination using the thumb here to make it more efficient as some mobilization. I will use some part of my hand. It could be the hypothenar or the thenar part of my hand here, as you feel comfortable. And I will have some fixation, and then I would move the lower part of the spine or even the pelvis. So moving the pelvis and moving through the pelvis, the segment under my hand here. So the spinosus is in the middle. I'm on the opposite side, contralateral side here, trying to push down, not too hard, but still enough to have a good fixation of the segment I want to mobilize. So again, remember, you don't have 20 degrees of range of motion in each segment. You have a few degrees, so it's not that much. We don't need that much of movement if we make it specific enough. So I press down, I turn, and then release my hand and come back. Now what I'd like to do is not starting from the neutral position and bringing to position into rotation here. What I'd like to do is even go a bit further here, have a fixation, and then bring here into rotation. I like to bring it a bit over neutral here, push, and then turn there. All right. Again, lower part of the lumbar spine, I feel it's very efficient and pretty common to have restrictions into rotation. And then thoracolumbar area is also an area that I feel which is pretty common here. Again, we don't have exactly the same range of motion in the thoracolumbar area than in the middle lumbar. So, of course, we should do our assessment and check for the mobility and also treat according to this. Okay, we have a question, probably.
We have an announcement. Unfortunately, we have some problems with the close-up camera, so we're going to have a short 2-minute, 3-minute pause to fix this, and we will continue afterwards. So don't go away. We'll be right back with the second camera rolling also. Okay, now we are back online. I'm really sorry for the technical issues we had with the cameras, but now let's continue. Hopefully you had some time to grab a coffee to yourself, and Kevin, please continue your demonstration.
Thank you, Vili. Again, please apologize for this short break. So we were speaking about mobilization into rotation here. We had fixation here on the opposite side. So I go above the spinosus here, and I go onto transverse process here on the opposite side. I have my fixation here, and then I would go a bit to that side, and then fixation here with this hand, and then come toward me until I feel some restriction. Come back, and here. All right, so we've seen now mobilization into flexion, extension, sideband, and rotation. Now we're going to use the same movements. We can use exactly the same movement to make this mobilization more on a broader area, or actually we can focus more on soft tissues. Now the movement will be bigger. It will look bigger because I don't make it so specific on one segment. Now, again, I can have a hold on both sides or one side, depending maybe on the size of my patient or size of my hand, or maybe the problem, is it bilateral, is it one side? Now the table now will be a bit higher because my pressure won't be that much toward the floor. It will be a bit more oblique down and cephal direction compared to the patient here. So I would have my wider hold. Now I'm not focusing so much on the spine. So again, my hold and push is more superficial here. I will have my fixation and bring into flexion. And again, as you can see, the movement is now bigger. I can even use a bit more tilt of the tables, bring the head lower here, and go into a nice movement into flexion here. Again, I release when I come back, and here. Now, as you can see from the direction of my forearm, the direction of the force is pretty upward. It's not only straight to the table here. All right. Now, I can combine this, and I could actually keep a bit of flexion, open the sideband and leave only the sideband direction open. So I would have my fixation now on my side here on the soft tissue. Again, pretty cephal direction of the force here. Good hold with my hand, and then bring into sideband here. Come back, release at the same time, and go. Now, sometimes you have pretty much tension on one side. For example, it could be the erector spinae muscles, or it could be maybe the quadratus lumborum here. And you might feel sometimes that it's very well reacting, and it's getting softer, and it's nice. But sometimes you might feel some tension that the patient cannot really release this area or relax this area. So what I like to use in this case is to ask the patient to actually bring his or her lower body to that direction. So sideband now to her left side. So I would ask her to bring the lower body to that side, and at the same time, I will do the same technique. So what I basically have is reciprocal inhibition and release. So reciprocal inhibition meaning that relax. If I have contraction here, active contraction here, I should basically have inhibition on that side. So it's something I like to use to make it more easy for the patient to relax that side, and the treatment would be more efficient. So reciprocal inhibition, how to use it with the movement and combined with soft tissue here. All right, so some example. Now, again, I can use, if you think about rector spinae muscles or quadratus lumborum muscles, they do extension of the spine, but they also do sideband. So if I have some tension on the right side, I can use both flexion to have some nice stretch here and fascial and soft tissue technique here, depending on the direction of my hand. But I can even combine with some sideband here and release. So what I like to do here is have my pressure here, go into flexion, and when I start to feel some restriction here, it's kind of, again, pulling my hand, I bring into sideband to the opposite side. So now I'm standing on her right side, and I'm bringing the lower body to her left side, there. And again, I release when I come back. So again, large hold, broad contact, focus is more on the soft tissue and more than on the spine itself. Of course, I get movement in the spine, but I'm not trying to mobilizate one special segment. I'm not more having some large movement here. There. The direction of my hand will have some influence on the tissue I focus my technique on. If the table is lower, my hand will be more straight down, and then I can focus more on soft tissue, muscles here. Now, if I have my table a bit in a higher position, the angle of my hand will change, and now I'm more on a superficial layers, so it will be more fascial technique. Here, come back. Go down until you feel some restriction, and bring into sideband, release when you come back. All right? Now, let's have a look at the last movement, direction of movement we can use in this for these techniques on soft tissue combined with movement. Now, again, it's rotation, so I will open here. Again, table is pretty low. Here, I can bring a little bit more into flexion, and the movement will be the same. Table is good to be low because then I can just hold my hand, and it's very nice for me, very efficient technique. And what I feel is that you have two ways to do this technique. You can anyway push here on the muscles, but then if I want to make it very efficient, I will push with the muscle on the muscles here, inferiorly, and I will bring toward her pelvis into rotation to the left here. So this will be pretty efficient. I have a pretty nice stretch on the muscles at the same time. Now what I've noticed is that sometimes this is even a bit too efficient, too strong. So if I want to make it a bit lighter, I can actually push and bring into rotation here. So this will be pretty nice on the muscles here. So I can use this maybe to start with, and when I feel that I have a nice reaction from the soft tissues, then I can go into rotation toward me, hold here, and stretch with a very controlled speed to make it comfortable for the patient here. Now on this one, you can even go up to the latissimus dorsi muscles here and have a very wide hold here. All right? Okay, let's go back into neutral here, there. All right, so this was for mobilization, and now I'm going to speak about some special techniques we can use. So let's say, for example, we would have some nerve root problem, maybe entrapment. Let's say it would be at the lower level, L4, L5, L5, S1. So something related probably with extension, sideband, maybe rotation, closing of the foramen. Now, if I have a closing of the foramen and this is provoking my pain, or the patient pain, then I would think about opening this foramen. Now, to open the foramen, I have several ways. I could use spinal decompression, so I would use the tilt of the table, and then I have the weight of the patient bringing the body into inferior direction. So I will have an opening of the foramen here. And so this is what we are going to start with, spinal decompression. So I will put some straps here. The first one I will put around the pelvis here. There, come to my side here. Now this should be comfortable for the patient. I mean, keep it comfortable for the patient, but still this should be tight enough. So if I try here, I can get a few fingers here in this space, but not too much, that this should be pretty tight. And this will hold the pelvis of the patient when I will be using some tilt in the table. Now I will ask you to bring your knees together, thank you, and we'll put this around the knees and here around that part of the table. There. Now this can be a little tight, but not too much. It doesn't need to really be very, very tight if this is tight enough. All right, from here, I will raise a little the table, and I will use some tilt down. So I will push down on the pedal here, and the head of the patient will go down. Now, as you can see, I have the weight of the patient going down, so we will have some spinal decompression here. And the idea is to have a hold in this position. Now, in this position, if you want to make it comfortable, if you have a patient who is pretty long, with the head coming here in the upper part of this support, then you can open here and leave it open so that this will move with the patient here. All right? Now, in this case, we don't really need that. From here, let's say I would aim at the left side. I would open the left foramen, for example, L4, L5, L5, S1. I want to open it more efficiently on the left side. From this position, I will use a bit of sideband here to the right. So if I have sideband to the right, I have an opening on the left side. And I can hold this position for a while. Now, I wouldn't hold it for very long, maybe 30 seconds, maybe one minute, even up to 2 minutes. Keep it comfortable for the patient, come back gently to a neutral position, and then after this, maybe use the tilt up to raise so that the patient gets time to have to go back to a standing position. Now from this position, again, I could even make it a bit more efficient, adding some flexion. Now, if you have some tilt down and add some flexion and you have sideband, this is pretty efficient, so you don't actually need a lot. Very, very nice to get some opening here on the opposite side. Okay. To come back, what I like to do is leave the flexion open, come back with the patient here. So this is this part of the table is coming back to neutral position at the same time. Very comfortable for the patient. In the spinal decompression, what we recommend is maximum of 30 degrees. Now the table goes into a lower tilt up to 32 degrees, so you won't need all of it, but about 30 degrees is the maximum recommended. And of course, keep in mind that if you have some contraindications related to blood pressure or blood circulation in the head, then please consider it. Now, very efficient for this area. So that was decompression, spinal decompression, and now we're going to go into traction. So the use of traction of the table will be used with this lever here, so open and turn, and the movement you will be able to get is this traction here. Now, so that the upper body stays and create a fixation, again, I'm going to use a little of tilt here, and a bit of flexion here. Now, even a bit more tilt here. Now I will hold here on the sacrum, hold here, maybe you can hold on the table here, maybe closer to you here, and I will gently push here into traction. So maybe you can even push here a little to get the movement at first, and then gently push here, and you will notice that even 1 or 2 centimeters movement, probably your patient will tell you already that, okay, I can feel the stretch. Now, it's a very efficient technique again, something that maybe we would like to use a bit more. It's very nice to keep it comfortable and to keep a light stretch, not to overdo it. So very nice to have some traction here in the lumbar spine, there. And again, you can use it only in this plane, or you could have a bit of sideband. So I would open the sideband, take a bit of sideband. Now I have sideband here to the right. I close it. This is very stable. And then I will again go into here, push a little here, go for traction. Now again, I have more traction on that side because of the sideband. All right? Okay, let's come back here, close here, come back into neutral. And again, after this kind of technique, what I like to do is open with this lever here. And instead of bringing fast the lower body into neutral position, again, I bring the table back into neutral position until it stops there. So pretty gentle. Again, after that, what I like to use, take the straps off, bring this part of the table lower, and the foot part will turn, having the feet of the patient on the support, and then little by little bring back into standing position. To go back to standing position, use 2 or 3 steps. So you would go from this position into about 20, 30 degrees, have a little break, maybe 20 seconds, 30 seconds, and then again go back, and then a second step here, 20 to 30 seconds, and then to standing position. This gives time to for the lumbar spine area muscles to get back again to activation, good activation, and also the blood circulation to come back to normal, I mean. Right, so we've gone to decompression and traction. Last, I will show you the drop, how to use the drop technique. So for the drop, you don't really need the straps. So let's take them away. Okay, so for the drop, come back into neutral position here. I think we are close to it. Table should be pretty low. Again, check for the positioning of your patient. You should have the ASIS on this part of the table here, and the contact will be on the sacrum. Now this technique, the drop technique, will use the function of the table where the table is going inferior and toward the floor. So it will be a combined movement here, inferior and toward the floor here. And I like to show this first to my patient. So soon I'm going to push here. I will ask you to breathe in and breathe out. And while you will be breathing out, I will push here and the table will do this short movement here. And then we'll come back, all right? Not to get too much surprise for the patient. Now, if you take a good contact here on the SIPS, you go medial, check for the sacrum base. Now, it's important that the contact is on the sacrum and not on L5, all right? Of course, I want to have some sharp movement between the sacrum and L5, so the facet joint will be in this direction here, maybe depending on the individual, a bit more sagittal, a bit more in this direction. What I will have with the drop is a movement into that direction. So very efficient in the case you have, if you notice that you have some restriction for L5, L4, maybe up to L3, so kind of a group dysfunction, some group of vertebra with restriction. In this case, I find it very interesting to first work on the lumbosacral junction and then check again. And sometimes I've been surprised that treating the lumbosacral junction, mostly if I have a restriction on one side, then makes it a lot easier to have movement in the lumbar spine. Basically, sometimes I didn't even need to treat the lumbar spine. So if I have a group of vertebra which have a restriction into sideband on one side or the other, it could be into flexion or extension, but mostly on sideband, then treatment of the lumbosacral junction is very, very efficient. Now, to do it, again, contact on the sacrum, a little bit of tilt down here, so we'll go there. Contact with my hand on the sacrum, make sure you're not on L5. Right hand is now the applicator, so the right leg should be behind with the heel high and the toes pointing in the same direction of the force where I want to push here. Table pretty low helps you to really create the force here. So this should be pretty accelerating movement. I will push with my hand and my upper body here until I get the drop, and I'll go a bit further. So it will go there, right? And then come back, right? So I would ask my patient to breathe in deep, and while the patient is breathing out, I will push and go there, right? So think about going, pushing so that you get the drop, and then until you have the table hitting the lower part here, keep on pushing until that point. It's pretty important because then you can get also the movement between the sacrum and the ilium here on the left and on the right. Now, this is really the basic of the drop technique. If needed, and if I notice that one side is more restricted than the other on the lumbar sacral junction, again, I can have my contact a bit more on one side or then on the other side. Again, make sure you're not on the SIPS, but on the sacrum here, right? Good, so that was the drop. So what we've gone through today, what we've seen, we first spoke about passive range of motion assessment, patient positioning, flexion, extension, sideband, rotation, and then mobilization, how to work into these directions. We've used a bit of tilt, we've used some soft tissue techniques, using these same 3D movement directions. And then we've seen some spinal decompression, some traction, and the drop. So really some basic stuff, but already I think many ways to help the patient in case of low back pain. I want to thank you again for today, and I will now give the microphone to Vili.
Thank you, Kevin, and thank you everyone on the other side of the screen. We're really sorry again for the technical problems we had earlier with the cameras, but we are going to edit this all together and send you the recording of the whole webinar all together. Like Kevin mentioned earlier, this is the basically basics of the lumbar section and what we can do with Manuthera with it. And to learn more and to see maybe more advanced techniques and things like this, please visit our Learning Hub with over almost 100 videos of different kind of techniques and therapy styles, if I may. Also, please send us feedback, send us ideas on what we can go through on the next webinars, and we'll for sure come back to you with the email on telling when is the next webinar online. And since then, thank you and take care, stay healthy, and let's see you again. Thank you.
Thank you.